and I'm the coordinator as your host today as we run through this webinar. And before we get started, just to run through the webinar housekeeping guidelines. In the chat box on your right-hand side, if you can type, if you haven't done so yet, I would like to request those who haven't done so yet to type in their names and the country where they're connecting from. And I think it would also be quite interesting for us to know if you're connecting with other people, you know, the number of other people using the same connection as you, that is having somebody in the same room as you using one connection, like the example on your screen showing. Like I'm Catherine Miawala, I'm from Zambia, and I'm sharing my connection with 4 other people. We don't want to necessarily know their names, but just the number of people. Then we're encouraging all participants to be muted, and also that their videos should be disabled. And obviously this is to allow the presenter to speak without any interruption, and also that we don't affect the internet bandwidth. Then also to let you know that there'll be a question and answer session at the end of the discussion, the presentation that we're having today. And we're encouraging the participants with any questions, you know, as we're going along, if you can type them in the chat box, we will log them and have them answered during the question and answer session, where you can also speak. If you'd like to speak, you can ask your questions there. Then also to let you know that this webinar is being recorded, and the link to the recording will be shared. So, you know, today's webinar is on lessons from the landscape analysis of electronic immunization registries in low and medium income countries. We know that there's been a growing interest in digital health solutions for immunization programs, particularly as they relate to data management. And in this case, we're talking about electronic immunization registries. Many countries would like to implement these electronic immunization registries, but then they have a lot of questions around them pertaining to issues like sustainability, the costs and the like, and you know, the challenges. So based on that, VillageReach launched a landscape analysis last year just to identify the electronic immunization registry implementation in the low and medium income countries. And in this webinar today, we'll get to hear the findings of these, the analysis, which actually revealed valuable insights into the deployment of electronic immunization registries. And I think the focus here is around sustainability, looking at the functional requirements and what are the promising practices that they got to find out, as well as issues to do with how we can improve immunization coverage. And we will also get to hear from the speaker, what the knowledge gaps, they identified, and also looking at the way forward to enhance the usefulness and the value of electronic immunization registries. So to speak to us today, we're privileged to have Jennifer Pancholi, who's a senior manager for digital health solutions at VillageReach. And Jennifer has a background in healthcare policy, research, and data analytics. And her career spans domestic and global healthcare, including service delivery, innovation, evaluation, as well as issues that address health disparities in underserved communities. And in her current position, her work focuses on developing partnerships and solutions to improve the use of digital health records. And these include electronic immunization registries. And she works across VillageReach's work with core and partner countries. And she also develops collaborations with the private sector partners just to ensure that the predictive analytics are contextualized, and also with the aim of advancing health outcomes in low and medium income countries. And Jennifer's academic credentials include a master's degree in public health, as well as a master's degree in international development from George Washington University. Well, I think there's a lot that we're going to learn from the presentation today, and I wouldn't want to take up much of our time with the preliminaries. A warm welcome to you once again, Jennifer, and I'd like to invite you to take the floor. Just walk us through the presentation for today. May I stop sharing so that you can share your screen?
Hi, Catherine. Yes, thank you so much for the welcome and for the opportunity to present here today on this really excellent webinar series. I'm just going to go ahead here and share my screen. And please do let me know when you can see it.
Yes, we can.
Great. So to start out, I thought I'd give us a quick overview of what I'm planning to cover. I'm going to very quickly introduce VillageReach for those that may not be familiar. And I'm going to give some highlights of VillageReach's current work with EIRs, digital immunization records. I'm going to talk through the purpose and methodology of the EIR landscape analysis that we conducted and discuss the findings specifically related to sustainability, functional requirements, equity, and promising practices for implementation. And then I'm also going to go into a little bit more detail on two specific questions that we had as we were getting into this research, one around ways to uniquely identify children, and a second around considerations when thinking through how to transition from paper to digital records. So quickly, who is VillageReach? VillageReach is a relatively small nonprofit with headquarters in the Seattle area. We also have offices based in the Democratic Republic of Congo, Mozambique, and Malawi. These are our core countries. But we also have staff and have been involved in projects in other geographies, most of which is in Africa, as you can see from this map on the lower left part of the screen. Our vision is a world where everyone has the healthcare needed to thrive. And our mission is to transform healthcare delivery to reach everyone. And VillageReach has a structured approach to how we work through our different projects and move them from stage to stage. We focus at first on learning and understanding what people need from the healthcare system, and have a focus on healthcare delivery at the last mile. We then move to developing and evaluate solutions, and eventually to scaling and transitioning these solutions to the final owner, which often is a government. And then we are committed to helping sustain our work over time and eventually to replicate it. So what work is VillageReach currently doing in EIRs and digital immunization records? We have two projects where we are implementing EIRs and planning for them. The first is called MVaccin, and it's in Côte d'Ivoire. In this project, VillageReach functions as a service provider. It's a collaboration between the Ministry of Health in Côte d'Ivoire, Gavi, and Orange. And in this project, VillageReach is doing a lot of coordination and management of activities. And one of the interesting things about it is that Orange has developed a cell phone-based application that functions as an EIR. I think most folks know that Orange is a telecom provider in many countries in West Africa. And the goal of this work is to address the lack of information that parents and caregivers in this country have on vaccination, which is identified as a leading reason for incomplete vaccination. Here's a quick project summary, and I just want to highlight that this work will target approximately 800,000 pregnant women and infants, and that it will be phased into approximately 50 health districts in Côte d'Ivoire over 5 years. And then we are currently in preparation, planning for an implementation of an EIR in Mozambique. And the opportunity here is that the Mozambique Ministry of Health is looking to improve immunization data quality, use, and resilience. Up at the top right here, this is a picture of some of the damage from Cyclone Ida in 2019. There was severe damage to immunization records as well as other health records. And this is one of the drivers of wanting to develop a more resilient immunization registry system. There's also a need to improve immunization coverage, and in the current COVID context, to catch kids up on missed routine immunizations and prepare for COVID vaccine distribution. So in preparation for this work, VillageReach has launched quite a few different pieces of research to best understand what's needed in the country in partnership with the Ministry of Health. And the first piece was to identify best practices through the conduction of this EIR landscape analysis. And then we've also worked on understanding user and stakeholder needs and are currently engaged in planning for sustainability through an EIR readiness assessment. But this presentation is going to focus really on this first piece, identifying best practices. So now I'm going to discuss in a little bit more detail the purpose and methodology of the landscape analysis. So this landscape analysis was begun in spring of 2019. And as I mentioned before, it was undertaken to ensure that VillageReach's planning efforts for the EIR in Mozambique were adhering to best practices based on information from existing implementations. And there really were 4 areas that we were interested in understanding: what's needed to encourage sustainability, what are functional requirements that are key, what can be done to improve the equity of EIR use, and also what are some implementation best practices or promising practices. And the findings from this work have influenced our approach to this work, but also has influenced our approach to the work in Côte d'Ivoire. So the methodology, this research really consisted of 3 parts. The first was a literature review. The second was a subject matter expert interviews, and the third was a targeted gray literature search. So in terms of the literature review, we were looking for published articles to do with 4 kind of categories. The first was EIRs in Africa, Asia, or Latin America, EIRs that were scaled, either beyond an initial pilot or had at least 50 locations, articles that discussed EIR implementation best practices or systematic reviews of EIRs. And we eventually identified 30 published articles with those criteria. A lot of the articles did discuss implementations that were, a few years old, and we were interested also in making sure that we were considering the most recent thinking around EIRs. So we also conducted 6 subject matter expert interviews, and this was a convenient sample, so experts that were known to VillageReach, but they did include immunization experts from PAHO, the World Health Organization, UNICEF, PATH, the Bill and Melinda Gates Foundation, and ONA. And then finally, as we were analyzing this information, we came to a couple of kind of additional questions that we wanted to dive a little bit more deeply into regarding unique identification of children and transition from paper to digital registries. And we also identified the BID initiative early on as a potential model for the work in Mozambique. And so we continue to collect some targeted gray literature to address those topics, which was also included. But I do want to acknowledge that there are other published literature, gray literature, and promotional materials on other EIRs that were not included in this work, just based on these exclusion criteria. So this is not an exhaustive literature search on all EIRs in all LMIC contexts. So the focus of the articles, or the story that we were starting to see unfold as we were analyzing these documents, is that several countries in the PAHO region were among the earliest EIR implementers of EIRs, and they were followed by a wave of implementations and LMICs across the globe starting around 2016. Many of the EIRs that were implemented in the PAHO region are well documented in the literature that we came across. And one significant challenge that some of them experienced was the inability to interoperate or permit data exchanges with other systems, including their own ministries of health. That's because these programs were developed for exclusive use by the immunization program. So these implementations really do offer many helpful lessons around sustainability, functional requirements, and equity. And then also the published literature as of spring 2019 on more recent EIRs was scarcer. The BID initiative, Better Immunization Data Initiative, is a notable exception, and we did include several of their publications in this work. So let's talk a little bit about the findings. So we identified 7 key lessons on sustainability. And the first is inspiring country ownership with early and regular collaboration with the Ministry of Health, other government, and stakeholders. One piece of this could be conducting an EIR readiness assessment. An EIR readiness assessment can help to define stakeholders and provide a process for helping stakeholders to think through some of the main components of developing a vision and a plan for EIR implementation. It's also important to think through who key decision makers will be, not just at as an EIR is introduced, but over time, as changes need to be made, who will be the key decision makers around, what's next. The second lesson is to articulate the value of an EIR to the overall health system now and in the future. So as many of us know, implementing an EIR is expensive. It takes time to implement well. And it's important for implementers to understand both the upfront costs of implementation as well as the long-term costs, and to weigh that against the benefits of the system, both in terms of lives saved, but also in terms of the value of the EIR to the overall health system infrastructure. So EIRs, as we all know, must compete with public health initiatives for human, financial, and material resources. And implementers will want to ensure that stakeholders are well aware of the costs and that there is a commitment to the system as a long-term solution. The third lesson here is to create a roadmap for system and data interoperability. The more interoperable that a system is, the higher the value is of that system. And there is currently increasing awareness that interoperability improves sustainability. To date, most EIRs have not been able to link across multiple health data systems. So it's important to think through how data sources can be linked in advance of implementing them. Implementers will want to ensure that projects are aligned with government ICT strategies, policies, or policy conversations. And one resource for this is OpenHIE, which is an online community disseminating best practices in health data interoperability at scale. The fourth lesson is to plan for continuous financial and human resources for the ongoing use of the EIR. It's helpful to map out the ongoing costs of maintaining an EIR, both regular maintenance costs as well as potential changes to the EIR system over time. And also long-term human resources and how to build and maintain those human resources is a key point. It's also important to define all necessary system requirements with stakeholders at the very beginning. A fifth lesson on sustainability is to actively understand vaccinator needs and have this guide solution development. So using a user-centered design methodology or a human-centered design approach to EIR development. It can be very helpful to consult healthcare workers during the design phase to allow for sufficient time for software development, and then to reconsult healthcare workers and have them test the system. In Albania, one example we came across, consulting with nurses in the design and testing phases of the EIR really turned those individuals into champions for the system. And while this is really kind of an ideal outcome, the important piece is that the system that is being developed or contextualized really is meeting the needs of the users. A sixth lesson is to approach implementation with flexibility in order to ensure that the system meets user needs. So consider that an EIR system that's designed must be able to adapt to new vaccines, new schedules, unforeseen changes. The BID initiative did scrap early EIR attempts in both Tanzania and Zambia and adopted a new system there because the initial systems were insufficient to meet their users' needs. And this last finding is to incorporate data quality and use components to reinforce the value of the EIR. The BID initiative, again, did create peer networks on WhatsApp, micro training videos, and data use guides. Additionally, supervision coaching tools can be used to, in low performing health facilities to help staff address existing challenges. So I want to talk for a minute about functional requirements. I'm just going to provide a brief summary of the functional requirements that we identified. We identified 11 critical functional requirements and 6 optional functional requirements. And there is quite a bit more detail about these in the actual landscape analysis report. So if you have would like more information, I encourage you to read the report. But I did want to highlight this very helpful article called Electronic Immunization Registries in Tanzania and Zambia, Shaping a Minimum Viable Product for Scaled Solutions. The BID initiative did a very thorough process for determining requirements for the EIRs. And that process and also the actual functional requirements that they determined were necessary for a minimum viable product are documented in this article and appendices, and I think they came up with 81 different requirements based on that process. So there's a lot of good additional information in this article as well for those that would like to dive in more. And then I wanted to highlight here one thing that VillageReach was thinking through as we were analyzing these articles is there's a lot that can be done with an EIR. And so the importance of thinking through really what are the goals of your specific EIR program and then wanting to match those goals with functional requirements. Because as I said, these systems are costly and it's important to think through, what functionality do you really need right away? And, how might the EIR be able to grow over time? So we identified 6 different implementation goals. 3 are here. This is the improve vaccine coverage and equity. Second, to improve dose timeliness. And third, to improve vaccine accuracy. And I just wanted to say a little bit about this first one, improving vaccine coverage and equity. This is clearly a key goal of many EIRs. And an important piece of this is to be able to identify both 0-dose children and under-immunized children. So it's important to be able to have access to information on births and deaths. Ideally, that would come from something like a civil registry, although a lot of times in most countries, that's not in an electronic format that can be easily integrated with an EIR. So some short-term solutions may be to include information collected by community health worker applications in select geographies. It's also important to adopt a system that has the capability to work offline, since many parts of countries don't have regular internet access. It's also very important to be able to uniquely identify children. And as I said, I'm going to talk a little bit more about that later on. The 3 additional program goals that we identified were improving immunization program efficiency, improving data quality, and improving primary healthcare service delivery. Regarding improving data quality, it's important to be able to enter data into the EIR system as close to the collection of that data as possible. So ideally, when someone is being vaccinated, that is the point at which that information is being entered into the EIR. It's also important to include data verification and completeness checks at the point of data collection. And then also including client management features to identify duplicate child registrations at the time that records are being created is ideal and important. I wanted to take a minute and talk a little bit about criteria for selecting an EIR. There are many different types of EIRs that are available. There's open source versions, customized versions, commercial systems, or software. And we identified a couple of criteria for thinking through what might be a good option for a specific geography. And those include the degree of control or customization required over the end product, dependence or willingness to be dependent on a single vendor versus flexibility to export data and switch platforms, the time that's available for creating or customizing a system, country level capacity or knowledge available to support the system over time, cost, including the balance between upfront and long-term costs, and the compatibility with existing health information technology that you might want to interoperate with. I also want to highlight this really excellent article by PAHO called Electronic Immunization Considerations for Planning, Development, Implementation, and Evaluation. This article or guide really goes through a really excellent overview of advantages and disadvantages of these different options. And then I wanted to pull out information on two specific systems that we came across in several of the implementations, OpenSRP and DHIS2 tracker. These are both open source options identified as global goods by Digital Square. This means that they're compatible with a wide range of existing health information technologies such as DHIS2, OpenLMIS, and are supported by a large community of online users. Okay, so findings on equity. So EIRs can be a valuable tool to improve coverage equity. Key to that, as I mentioned a little bit earlier, is the ability to identify under-immunized children, which are often referred to as dropouts or defaulters. These are individuals who've had, some of their schedule completed, but other parts of their schedule are out of date. And unimmunized children. So these are children often referred to as zero-dose children that may never have actually received a vaccine. And this is possible assuming that data is actually available and processes are developed to allow their identification. And it's possible that more detailed data on defaulters collected in the EIR can be used to better predict and prevent missed immunizations. EIRs are also particularly helpful for serving migrants who may be wanting to access care across multiple facilities, depending on the size of the geography of the EIR. Program implementers must also ensure the equitable implementation of EIRs. Think about focusing trainings on those users who are least prepared to use technologies in order to prevent unintended gaps in data quality. And finally, it is very important to prevent the misuse of data and to think through what's necessary to protect disadvantaged groups. I think two pieces of information that we came across as specifically highlighted that it's important not to collect our ethnicity and religion due to their sensitive nature. And so let's talk a little bit about promising practices for implementation. We identified 6 topics where there were promising practices from the literature. These included change management, data use components, peer learning and support, targeting follow-up to low-performing areas, training consideration, and transitioning from paper to digital records. And I wanted to talk in a little bit more depth about a couple of these. Regarding change management, it's important to identify a clear change management plan, and understanding how healthcare workers have previously embraced change can be helpful for designing this process. The BID initiative specifically recommended asking healthcare workers open-ended questions about the EIR and its use during that design and testing phase in order to develop a communication strategy that is able to address any staff concerns about its use. And then looking again at data use components, it is critical to implement data use components to really address data quality and decision making based on the data, creating that virtuous cycle where data is used, which reinforces the continual use of the EIR. And then I also wanted to comment on training considerations. Training is obviously really important for an EIR, which is a complicated system to use. The BID initiative employed on-the-job training approach, which allowed for iterative learning over time. So early trainings focused on first just using the EIR, and then as healthcare workers gained confidence, later trainings several weeks later focused on ensuring data quality. So there's a high level of data quality being entered into the system. And then after that was absorbed a little bit later, trainings focused on how to use the data to improve decision making. And I also, again, want to point out a helpful article called 3 Waves of Data Use Among Healthcare Workers, the Experience of the Better Immunization Data Initiative in Tanzania and Zambia. This is a really great article that describes implementation practices for how the EIR was launched in the BID initiative, with lots of great nuggets in it. So let's talk now about a couple of key questions that we were thinking through. One, this first one, what are the options for a unique identification of children? So as we were doing our analysis, we came across 3 different ways for generating unique identification for children in an EIR. The first is human generated, which I think is self-explanatory. The second is machine generated, and the third was biometric identification systems. So looking at the column on the left in orange and thinking through what were some of the options for machine generated ID systems, one common system is to use barcodes and QR codes. So when using this approach, a unique ID is generated by the underlying EIR software system, such as OpenSRP. And health workers register a child at the facility or immunization session using a tablet, which is automatically generating the barcode or QR code with a unique ID number on it, and then assigns it to that child. Then that same barcode or QR code is printed and adhered to the child's health card. And when children return to the health facility and have that card, the healthcare worker is able to help access their record. Another approach that we saw was using SIM cards as the basis for caregiver identification. And then a third option that we saw was near-field communication chip cards. So again, a machine-generated unique ID is linked to a near-field communication chip-enabled card. So it's a card that the caregiver or parent takes with them and contains all of their child's health information on it, or specifically their immunization information on it. And a healthcare worker can access the information on the child's card by simply holding it up near a tablet that's capable of reading it. There are some challenges for using these machine-generated IDs. One is the ability to integrate data across health systems, thinking about how you pair up unique IDs that have been generated by different systems. A second challenge is the potential for accidental duplicate IDs or misidentification if someone returns bringing their child in for an immunization and doesn't have their records with them. The other options that we are seeing starting to develop are biometric ID systems. We identified 2 potential vendors. The first is Simprints. So Gavi and Simprints, which is a UK-based nonprofit social enterprise, have collaborated to develop a biometric innovation that's linking children to health records through fingerprints. So health workers use a pocket-sized fingerprint scanner to scan an adult's fingerprint. And then the scanner wirelessly syncs with the health worker's tablet that houses an EIR. So this enables the linkage of the fingerprints to a child's immunization records. And I will note that the hardware is robust, portable, low cost, and wireless. we came across a second vendor, Element, who has been working on an artificial intelligence powered software only biometric recognition solution. The main challenge with this to date is the inability to reliably perform biometrics on children and infants, although that is currently in development. So if you're going to use these systems at this point, it would be using a fingerprint or biometric identification for the caregiver or parent of a child. And then another kind of topic of interest to us is thinking through considerations in transitioning from paper to digital records. So in our research, we came across 3 different contexts where EIRs had transitioned from paper to completely digital registries in at least some health facilities. And those 3 areas included Tanzania's Immunization Registry, TIMR, Vietnam's Immunization Registry, IMREG, which is now called the National Immunization Information System, and Chile's Registro Nacional de Inmunización. So thinking about this a little bit, I think we didn't come across any context where a government was comfortable moving directly from paper records into electronic immunization registries. So what usually happens in most countries is that there is this dual system where healthcare workers are both continuing to use the paper process that they've been using, and then also start using the electronic immunization registry at the same time. And as you can imagine, that introduces a fair amount of burden for those healthcare workers. So a first consideration in thinking through this transition is just to prioritize minimizing the length of that parallel reporting system as much as possible. A second consideration to think through as you're implementing an EIR is what is the plan for the transfer of data from the paper registries to the EIR? And we came across 2 different approaches. The first in Kenya was to pre-enter the data from the paper records into the EIR. And as you can imagine, this would work well in a context where you have a high level of confidence in the quality of the data in the paper records. A second approach, which was used by the BID initiative, was to hire data entry clerks to verify and enter data in the first few weeks. So the way this works is that in those first couple of weeks, there are additional staff, the data entry clerks, and as families come in to immunize their kids or seek services, they can sit down with those families, talk through their records and make sure that the data in them is accurate, and then enter them into the system. And I believe the BID initiative did this for 4 or 5 weeks. And then in most health facilities, the healthcare workers after that were able to just enter records as families came in. A third consideration is to determine transition targets for what is the right time to move from a dual system to just the EIR system. We didn't come across a great kind of list of targets, but it did appear that it's very important to think about this in advance so that this doesn't become a stumbling block for health facilities and workers don't end up using these parallel reporting systems more than is necessary. And then a final consideration is to think through allowing a phased approach to transition. So if one health facility in a region has reached the target to transition, allowing them to go ahead and transition, even if health facilities around them weren't quite ready yet. So this is just a quick reminder of where you can find additional information from this report. It's available on our website so that folks can access it after this presentation if they want. And that's really the end of the presentation. Again, thank you to Catherine and the BID Initiative for the opportunity to present this work, and happy to get a chance to talk about it with folks who may have questions.
Thank you so much, Jennifer. That was really enlightening. And we've come to the part where we can now get questions. And I saw quite a number of questions come in. So what we'll do is let me tease out all the questions that were dropped into the chat box. And then if you've got, to the audience, if you've got any question, maybe you could raise your hand because we're allowing you to speak as well. Just for a start, as people are thinking around, more people are thinking around questions. Jennifer, there was a question on, how you're measuring success in Cote d'Ivoire, because it's a country with quite a high dropout rate.
Yes, thank you for that question. So we have been implementing that project for less than 6 months and are about to do our preliminary evaluation. And I'm sorry that I don't have the details of the specific questions that will be asked in that evaluation, but I know that we are going to be conducting it in the next month or two. And if you wanted to follow up with me afterwards, I can get a little bit more details on what those specific data points are.
Excellent. And I think that question was posed by Dr. Carolina, but I think she's dropped off at the moment. I hope that actually answers her question, and we will let her know that you will share that, the specifics with her. Then there was another question on, if the PAHO countries have their specifics as compared to the Afro region in, many respects. Are you able to expand on the preconditions in the PAHO countries for an electronic immunization implementation that may not be present in the African setting? So, what were the differences there? Are you able to expand on the preconditions between PAHO countries, that's in the Latin America, and the African countries?
So I guess two things. One, the articles that we came across from implementations in PAHO, as I mentioned, were earlier on, were for the most part occurring like 5 years at least earlier than the implementations that were occurring in Tanzania. So even in that amount of time, advancements in technology had changed quite a bit. So, what you saw in some of those countries is developing a customized system and implementing it and not really having a chance to think through what the longer term implementations would be, or even, having a good sense of how those systems could be well integrated with other data systems in their countries. And what I was seeing in the, I think, 3 examples in implementations in Africa was, they were again happening like 5 to 7 years later. So there was a lot that had changed, both in terms of thinking around EIR implementation and in terms of technology. But there were kind of a lot of similarities in the things that were talked about from a sustainability perspective. And so those lessons learned from sustainability that I shared really were were echoed across those different contexts. So I'm not sure how well that answers the question, but just to note that, it's, I think, increasingly important to think through what are the connections between the data points, how thoughtfully have we considered the long-term costs of the implementation, and how have we been able to pull together the stakeholders with that longer-term plan in mind?
Oh, thank you so much. I hope that it ably responds to the question. There's another question here on what's the approximate success rate of transitioning from paper to digital based on early experience?
The approximate success rate?
Yes.
As in, like, what percentage of health facilities were able to transition?
I'd like to believe for the is that what you're asking, Chandra? Well, I'd like to believe so. So maybe you can just respond.
Yeah.
Yes, correct. Yes.
So that is a great question. And that level of information I did not see in the published literature. I don't know if there's anyone here from the BID initiative's work, and I think it was Tanzania, that wants to address that and might have more information that's not been published.
Thank you so much. Do we have anybody from BID initiative? I think I've seen members of BID initiative. Masaina, Paul, Dinus, I think you're all on board. Especially Dinus from Tanzania, I think. Tanzania.
Yeah, yes, Catherine. Can you say it again? Sorry.
There's a question about the success rate of, transitioning from paper-based to digital health solutions. What's the success rate? Have you guys transitioned fully from paper to digital?
Yeah, so yes, so far we have started with one region as a pilot area, as a pilot region to learn any challenges, success. Then we move to another region. So from one region that we started with, next month we'll also start for another 3 regions. So one of the success is the data flow, like how healthcare workers use the system and how data move from facility level to higher level. That's the one thing. But the second thing is the technical perspective of the system itself. Does it help, like, synchronizing data? Does it help health workers to capture data and keep it as they want? That's another thing. Another is on the leadership part. Do the leaders or coordinators from the district or regional level support healthcare workers to an extent that when they need support, technical issues, or any other issue, they get real data on the real time? That's what we are doing. But also another way, it has been also a challenge when there are still change management issues, because their mind are still on the paper base. So also you need to see on the change management.
Dinus seems to be breaking. Dinus? Okay, she seems to be breaking. So I think what she was sharing was, what they've learned from the pilot that they've done in one particular in one particular region. Does that answer your question?
Yes, thank you. Thank you so much.
All right, my dear. Thank you. There's another question around to what extent the landscape analysis explored the electronic immunization register opportunity for primary health care and not only focus on immunization in the country?
Yeah, that's a great question. And let me just pause and say to the prior question that there is some details in the actual landscape analysis about the number of health facilities that had transitioned from paper to electric only systems in those 3 countries. So there is some additional information in the landscape analysis. And then in terms of exploring opportunities to advance, I think you said primary healthcare.
Yes.
Yeah.
Yes,
so,
primary healthcare.
So I'll say that while this wasn't something that really came out in the article, in the published articles that we reviewed, it's something that VillageReach is giving a lot of thought to. There are systems like OpenSRP, which is the system that the Mozambique Ministry of Health is considering implementing, which are essentially electronic health records in many respects, and have different modules that can be used for tracking different health outcomes. There's also systems like OpenMRS, and I think that it's important to think more about the way to connect those different systems in order to create a primary healthcare record that it really tracks, not just for children, but for all populations. I think that's an area that's really important to be thinking through right now, especially in the context of COVID, when there's likely to be a vaccine for all populations that will need tracking. So I think it's a great question.
Thank you so much. Then there's another question. This one is talking about, are there any measures put in place to, sorry, it moved up. To ensure that a child has only one unique identifier or to avoid duplication? Were you able to come across issues to do with that? Mm-hmm.
Yeah, so kind of VillageReach internally, as we're thinking through these options for the best way for unique identification, that's one of the kind of the 5 areas that we think EIRs could be more effective and efficient. My understanding, for example, of many existing systems that use, for example, QR codes, is that you are basically given a list of potential duplicates that need to be reconciled later at a later point, which obviously presents some problems. And we're very curious about the biometric options that I presented in this presentation in terms of their ability to really uniquely identify somebody, given that there might be people with similar names or similar birth dates, because that's obviously something that your unique biometric ID can't be duplicated.
Thank you so much. I think we can take, one more question, which is talking about what are the minimal requirements regarding death or born register in the country to be able to implement the electronic immunization registry?
Well, I think there are a lot. So I'll just talk about the bid initiative system. And if someone on this call has better information and wants to correct me, feel free.
Yeah, sure.
But my understanding is that the way that program was set up, healthcare workers are asked to register infant births within 48 hours in the system. So I'm not aware of any systems where information from a civil registry is, from an electronic civil registry, is automatically entered into the EIR. I mean, that would be like a wonderful system, but the examples I've seen are just encouraging community health workers or healthcare workers to enter that information in within 48 hours of a child's birth.
Thank you. Here's an interesting question. What are some of the change management interventions that Tanzania has applied to change the mindset of the health workers to use electronic databases? I'd like to believe this one is asking, I think, because Dinus alluded to this. She brought in the issues of change management. So I don't know if both of you could respond to this, if it's possible, if we can have Jennifer and Dinus respond to this. I think this would be interesting.
And can you read that question one more time?
What are some of the change management interventions that Tanzania has applied to change the mindset of the health workers to use electronic databases?
Yeah, I mean, the primary ones that I'm aware of are the human-centered approach to the development of the EIR, where healthcare workers, are consulted kind of along the process in order to ensure that the system is meeting their needs and that they have an opportunity to test it and use it before it's fully implemented. And then also, sitting down with healthcare workers and asking them those open-ended questions to develop a communication strategy. But I didn't come across the details of that communication strategy and would love to hear more about that.
Thank you. Dinus, would you like to add anything to that?
Yes.
Are you still on board?
Yes,
Yes.
I just want to add one thing that was very important: engagement of Ministry of Health from higher level to lower level, where a regional level, that is a regional health management team and a country management health team, were engaged, and they are the ones that were communicating the message of using digital health. And then using district immunization mentors and national immunization mentors are the ones who have been communicating the message of using digital solution. And it was easy for the healthcare workers at frontline to trust and to own this system.
Oh, amazing. This is amazing. So we're talking about the country ownership here. And then maybe we can take, there was one last question, which is saying, is the system designed to generate reports for primary healthcare service programs?
So I'm aware that there are a couple countries using EIRs where there are kind of additional primary care data that's collected, like information regarding stunting and nutrition. And those EIRs I'm aware of were the registry in Vietnam, and I believe the registry that's being currently used in Rwanda. And so I don't know about the details of the reports, but I'm assuming that since some of that information is being collected, that there must be a way to access that information. So I don't know if anyone from those two countries might be on the call, but those are the two EIRs that I'm aware of that have started to collect additional primary care health data.
Excellent. There were two other questions. This one is talking about, well, it's actually, they're asking if we could share the reference material of listed in the EIR literature. I'm sure there's something available in the link that you sent, Jennifer.
Yeah, so two things. We have a kind of a traditional list of references in the landscape analysis, but we also have an appendix where we go through each of the articles and talk about kind of, or pull out, what region that EIR was implemented in, and list a couple of other details to help folks figure out kind of what's the most relevant information among those articles for them. Thank
you. Then there was one which is talking about the prerequisites for establishing and implementing the EIRs. That sounds like one topic of discussion for another day, because I think it's talking about, with that one, it means you'll be getting into the issues of like the EIR